Hello, everybody, again, and welcome to the second part of 14th Brian Boren School of Pathology. I hope you enjoyed the break as well as you enjoyed the previous sessions. I hope that you will enjoy the second part as you did the first one. So we proceed again with Dr. Cyril Fisher. He will, in the next 1 hour 40 minutes approximately, he will give two talks. One session is about spindle cell lesions. Spindle cell tumors, soft tissue tumors, and the second session is about Ewing sarcoma gene 1 rearranged soft tissue tumors. Dr. Fisher, please.
Thank you very much, Samir. Is that okay? Yes? Okay, thank you very much. And good afternoon, everybody, or whatever time of day it is. I must say it's a pleasure to be in touch with so many people from so many countries, all without moving from my chair. Doesn't get any better. And I did enjoy those presentations as well in the break, so thank you very much to everybody. So I'm going to talk now about spindle cell soft tissue tumors. This is a huge field, so I've selected some topics with particular emphasis on updating on new entities where they are available, just again, partly so you're familiar with them and know the range, and also perhaps to amplify some of the more basic concepts as well. So what I'll talk about is fibroblastic tumors, myofibroblastic tumors, some peripheral nerve sheath tumor concepts, and then a little bit at the end about synovial sarcoma, a couple of new developments. Let's start with fibroblastic sarcomas. Fibrosarcoma has always been a contentious area. Kim talked about the old days of MFH, and when MFH came in, fibrosarcoma disappeared. It had previously been the most popular sarcoma, but then it came back again in the 90s with the delineation of these separate entities, many which are actually characterized by the stroma, as you can see by the terminology. One of the problems with fibroblasts is they don't have specific markers. So at that point, when these tumors were defined without molecular findings, this depended on the morphology, and full marks to the pathologists of the day, because all of these have turned out to be genetically distinct entities. We'll talk about some of these. Let's start with dermatofibrosarcoma protuberans, which is, of course, a relatively common superficial or skin tumor. It doesn't always protrude like this. It can sometimes be plaque-like. And here it is again infiltrating into the subcutis. And here you see the very typical tangential or parallel array of infiltrating tumor along the interlobular septa, parallel to the epidermis. Of course, this is always said to have a monotonous storiform pattern, and there it is, very uniform cells because it's a translocation-associated neoplasm. It's diffusely and strongly CD34 positive, as we know, and there are a number of morphological variants which are not so easy to diagnose, apart from the usual one. Here are four, for example. The myxoid DFSP can be very difficult if there are no more typical areas. What you have to do is imagine you're removing the myxoid, and it all comes together with a nice storiform pattern, but that can be difficult to diagnose, particularly as other fibroblastic myxoid tumors are CD34 positive, including myxoma, myxoid SFT. Pigmented DFSP or Bednar tumor is relatively uncommon, but it has scattered melanocytes, S100 and melanocytic marker positives throughout, no prognostic significance. Myoid areas are very occasionally seen, they're actually myofibroblastic. And a specific clinical variant, giant cell fibroblastoma, predominates in childhood and can recur or form part of a regular DFSP even in adulthood. The most clinically significant variant, however, is fibrosarcomatous transformation, manifest by fascicular rather than storiform architecture, and increased mitotic activity, usually more than 10 per 10 high-power fields, and in any case more than 5. And this is because this can infiltrate locally, recur, and very rarely metastasize. The CD34 can be lost or partially lost, but all of the variants actually have translocation that can be useful for diagnosis and predicting therapy. The most common and the majority is the collagen 1A1, platelet-derived growth factor beta, and the recently been described some variant genetics of DFSP, all looking the same, two of them fibrosarcomatous, and one of them predominating in the breast. These are all very small numbers of cases, as is the way with molecular discoveries. One case is enough, usually, to be published. So all the variants have the fusion, but they don't all express the transcripts on PCR, and you need to know that because platelet-derived PGFP is a ligand for PGFR, receptor tyrosine kinase, and so we can use inhibitors for this tumor in locally advanced or metastatic disease, provided the transcripts are there, in other words, that it's going to respond because it has the right genetics. Now, the next entity that's been established in recent years is low-grade fibromyxoid sarcoma. This began as two cases in 1987 by Harry Evans and MD Anderson, with a subsequent report of 12 cases. And interestingly, these had originally been diagnosed as fibromatosis and then manifest again with metastases and local recurrence, which would, of course, be very unusual to have a metastasis in fibromatosis. Now we know they form a slowly growing mass in limbs, trunk, or inside the abdomen. And these figures are lower now because we're picking them up earlier and we are defining the cases more clearly. Here's an example of intramuscular low-grade fibromyxoid sarcoma with a myxoid area there, a large gross myxoid area. Typically, this has a whirling, swirling world pattern of fibromyxoid stroma with collagen fibers in a vague storiform pattern, embedded in which are the cells, which vary slightly, but often have quite distinctive angulated nuclei, like a diamond shape there, or pointy at one end and then abruptly cut off, which is a little unusual and fairly distinctive for spindle cell tumors. Other features that may be found are rosettes, and this variant with rosettes was initially defined as a separate tumor, hyalinizing spindle cell tumor with giant rosettes. We now know it's the same. And then other areas can be more myxoid. Note the lack of pleomorphism, little multinucleated giant cells, or more neuroid-like whorls. So the morphology of this tumor has a wider range than was originally appreciated. Of course, the marker for diagnosing this tumor is MUC4, which is positive in the vast majority of low-grade fibromyxoid sarcomas, but negative in most of the mimics. It is also positive in synovial sarcoma, ossifying fibromyxoid tumor, and some other tumor types, some of which I'll be talking about later. And yet these are different and are not likely to be confused morphologically with this particular tumor type. Just a word of caution, in intra-abdominal tumors, my colleague Dr. Sway described DOG1 expression in low-grade fibromyxoid sarcoma. If you think you have a GIST and you do a DOG1, you will have a GIST, GI stromal tumor. So always use it as part of a panel, and don't forget the MUC4, and the CD117 will be negative here. So we found some years ago now, 18, that low-grade fibromyxoid sarcoma hyalinizing spindle cell tumor had a common translocation, turned out to be FUS-CREB3L2 fusion, further characterization of a larger series, multi-center, showed FUS-CREB3L1, and this means you can use FISH for FUS to diagnose this tumor with some confidence, and you get very nice break apart using the FUS probes. Unfortunately, there are other variants now, as always, so some have EWSR1 CREB3L1, and a subset have YAP1 KMT2A fusion, and these are MUC4 negative. So if you think a tumor looks like low-grade fibromyxoid sarcoma and it's MUC4 negative, try and get the NGS done, or if you have it, PCR, for this fusion, and that will clinch the diagnosis for you. Now, a related tumor, or not strictly spindle, but more epithelioid, is sclerosing epithelioid fibrosarcoma. And this again was described in the mid-90s in a series, rather tellingly called Variant of Fibrosarcoma Simulating Carcinoma. A second series of 16 cases involved more deeper tissue and bone and extended the spectrum of this tumor, which can be quite large, deep-seated in soft tissue or affecting bone, in adults, middle-aged, young adults, and with a high recurrence and metastatic rate. It's a more aggressive neoplasm on the whole than low-grade fibromyxoid. Here's the morphology, and you can have large foci of dense sclerosis. It's a very hard tumor when you slice it. With islands of cells. The cells are very often rounded with clear or no cytoplasm, and you can see the fibrous stroma, often with thick hyaline bands, here mimics lobular carcinoma of the breast, infiltrating with a serous stromal response. Many of these tumors, if not the majority, are MUC4 positive, which is therefore also useful as a diagnostic marker. Some of them have epithelial markers focally, and the fish of this shows usually not FUS, but EWSR1, CREB3L1 in many cases. You will see, though, under the term rarely, that lots and lots of new fusions are increasingly being described in this tumor. This raises the question that we will come to again later of how do you define a tumor? Do you define it by the genetics, or do you say, well, this is the tumor X and it's got lots of different genetics? The jury's out on that, I think. You'll notice that this latest one, HAM1, I should say, MSCOA2, is also the fusion of mesenchymal chondrosarcoma, so more confusion. Molecular pathology is entering the era of immunohistochemistry in the sense that lack of specificity is becoming a little bit of an issue. This is a picture very kindly provided by Kin of a YAP1 KM2TA MUC4 negative sclerosing epithelioid fibrous sarcoma, and you can see that it's epithelioid round. It's rather difficult to diagnose, and it could look like carcinoma or even lymphoma. But in between, you've got these thick collagen fibers, so it is a variant of sclerosing epithelioid fibrous sarcoma, genetically proven. Now, hybrid forms occur between sclerosing epithelioid fibrous sarcoma and low-grade fibromyxoid sarcoma. These are generally aggressive and behave like SEF. They're usually MUC4 positive with a FUS-CREB3L2, but some of them are MUC4 negative with the fusions as shown here. And you can just see that there's the low-grade fibromyxoid, and here's the sclerosing epithelioid component. So the next entity, and it is true the names are confusing. Once you are, however, recall and understand the genetics, it falls into place because they do have distinctive appearances. So myxofibrous sarcoma is a common tumor in older adults and on the extremities, and it presents as a subcutaneous lump. And one of the hallmarks of this particular tumor is that it recurs frequently, and when it recurs, it can recur with higher grade malignancy. We call this grade progression. When in the retroperitoneum, such tumors are often MDM2 positive and are regarded as a pattern of dedifferentiated liposarcoma, and you've heard all about that from Ken. So the terminology, though, is remaining because this was called myxoid MFH. It was one of the malignant fibrocystoma variants for quite a long time. Before that, which is quite a long time ago, it was called myxosarcoma. So we've inserted the word fibroid because they are indeed fibroblastic. This is the typical appearance, and it shows you the random and varied pleomorphism throughout the tumor with the myxoid stroma. Notice the vacuolated fibroblasts, and we've already heard why these aren't lipoblasts. They do not have rounded, completely clear vacuoles. There's no nuclear indentation, and you can see material within the vacuole, which is actually the stroma being secreted. And what happens is a little window opens. You can see this nicely ultrastructurally, and the stromal substance comes out and obviously contributes to the stroma. Here's a more pleomorphic or more cellular variant at the bottom left, and notice the slightly thick-walled, curved blood vessels, which are quite different from those of myxoid liposarcoma. And remember also, this tumor, when it recurs or even de novo, can have more pleomorphic areas, which help you to make the diagnosis because this has no markers. The low-grade tumors have CD34 because they're fibroblastic. The high-grade areas have smooth and muscle actin because they're myofibroblastic, and this is ultrastructurally demonstrated. However, unlike the other fibrosarcoma subtypes, they do not have a specific genetic abnormality. They're complex karyotypic tumors. They're actually low-grade versions of UPS. So actually, the term myxoid MFH was not bad because it was the myxoid variant of the higher grade MFH, the lower grade variant. So there's a summary of the types of fibrosarcoma and the common genetic changes in each where known. I talked about mixed inflammatory fibroblastic sarcoma this morning, earlier, and I won't go into details of infantile fibrosarcoma. It's a whole subject of its own, although the ETV6 NTRAC3, and we've just heard a little bit about this from Samir's excellent presentation, is the commonest fusion. Now let's consider CD34 positive spindle cell tumors. We've mentioned some of these. It's a common diagnostic situation, a fibroblastic looking tumor with CD34. Where do we go? We've talked about DFSP, superficial CD34 positive, and PRDM10 range soft tissue tumors. I just want to talk a little bit about two benign tumors that come into the differential. One is perineurioma, usually subcutaneous, and this is composed of long, slender perineurial cells, and you may appreciate very, very long bipolar processes, one from each end of the cell. And these are demonstrated by epithelial membrane antigen staining. It's very faint and slender because the processes are very slender and faint, if you will. Other markers that are useful, GLUT1 and Claudin-1, but these are also CD34 positive tumors. The best way to prove these, and I apologize for this single electron micrograph in the whole day, it's not approved anymore, electron microscopy, but I used to do it, and it's actually very contributory in certain situations. This is perineurial cell tumor, and you see these very long processes covered by a continuous external lamina, which is what is EMA positive, and there's also micropinocytosis, which is another hallmark of this tumor type. You can actually see this mimics the pathology here, the morphology a bit. The other CD34 positive fibroblastic tumor you need to be aware of is the intramuscular myxoma. This is usually hypocellular with bland, featureless spindle cells or stellate dispersed in a myxoid stroma, which has delicate collagen fibers, some muciphages. There is a cellular variant that's more difficult to diagnose, but I thought we'd keep it straightforward for now. No atypia, no mitosis, CD34 positive, and all the other markers negative. And this, by the way, is the panel I use for intramuscular myxoid tumors to exclude nerve sheath, perineurial cell tumor, which can be myxoid, rhabdo, smooth muscle tumors, and also low-grade fibromyxoid sarcoma. And remember some of these, particularly in Mazabros syndrome, has the GNAS mutation. Now, Kin mentioned solitary fibrous tumor, and I'm going to talk a little bit about some other aspects of it. This tumor occurs at any site. In the soft tissue, it's commonly subcutaneous, but also very commonly intracavitary. That's to say, in the thorax and the abdomen. And of course, pleural ones were probably described first and are very well known. It's a circumscribed tumor here, not usually encapsulated, quite cellular here, and often with a peripheral focal hemangiopericytic pattern. There can be cellular and fibrous areas juxtaposed. The cells are short and uniform and randomly orientated. This is a so-called patternless pattern. There can be fat incorporated, and this was initially described as a subtype called lipomatous hemangiopericytoma. And I should add, the term hemangiopericytoma in soft tissue work has been almost entirely replaced by the term solitary fibrous tumor. It does persist in neuropathology for some reason. And this here with giant cells in the bottom right was called giant cell angiofibroma, but is in fact a variant of solitary fibrous tumor with giant cells. How do we know? Well, they all have the same immuno. They have CD34, BCL2, and CD99. But in addition, they all have STAT6 positivity, and this is the result of NAB2 STAT6 fusion. You can't do FISH because these genes are very close together in the same chromosome. So you have to do PCR. But actually, the immuno is so good, it's so clean and reliable that you tend not to need to go any further to make the diagnosis. It should be diffuse and nuclear for STAT6 because it is also positive but more weakly and cytoplasmically in some other tumor types as listed here. Interestingly, you can have strong staining in D. diff liposarcoma, which can be a confounding problem in the abdomen, except of course you do MDM2 as you've heard, and that's the end of that. But this is not due to rearrangement, this is due to amplification. Now, we've heard about dedifferentiation. So there is an entity of dedifferentiated solitary fibrous tumor. This is an abrupt change from typical SFT to high-grade pleomorphic sarcoma. The term dedifferentiated could be debated because it should mean the loss of differentiation and an undifferentiated neoplasm. In the case of SFT, both components are fibroblastic. So you could argue it's not dedifferentiated, it's poorly differentiated. But powerful people have gone for this, and it's not worth any longer arguing. But I think it's been accepted that this terminology is there. And of course, it does mean a higher grade behavior, because anything that's quite large with this change will metastasize. You can also, and you lose the markers sometimes, CD34 and sometimes STAT6. You can see heterologous elements, including rhabdomyosarcoma, and this is heterologous osteosarcoma within dedifferentiated SFT. If you just saw this in the abdomen, you would first think of dedifferentiated liposarcoma with osteoid, osteochondroid differentiation. But you look for other areas and you do the MDM2, really is your best sort of approach. Now, I mentioned earlier that we're trying to replace in some tumors benign and malignant with risk assessment. And solitary fibrous tumor has been subject to some to application of a risk assessment paradigm, mainly from Dr. Demico, then at MD Anderson, now in Toronto. And this shows the use of, it's a bit like the French grading system for sarcomas. You have three parameters. You have age, with a cutoff of 55. You have tumor size in tranches of 5 centimeters. And you have mitoses, but rather lower than the French system. You have 0, 1 to 3, and more than 4. And it's interesting that the 4 cutoff was the original cutoff in Dr. Enzinger's seminal paper on malignant hemangiopericytoma, which presumably was a paper about these tumors, although this tumor had not been invented yet. And you add up the figures as usual, and you come to low, moderate, and high. And this shows quite nicely 3 different curves for metastasis-free, and probably 2 curves for not dead of disease. So this can be used to predict in a way, although we don't have any specific therapies. Now, just while I'm still on CD34 positive spindle cell tumors, I should mention vascular tumors. It's not usually a problem. They are CD34 positive. They're not often spindled, but they can be, and so look for more either vasoformation or for epithelioid areas. And of course, CD34, then you have CD31, FLI1, and ERG, which is very useful as an endothelial marker. Also in Kaposi, another spindle cell tumor with CD34, not so often though, better with 31 and ERG, but also of course, specifically here, HHV8 in nuclei. A word of caution about ERG. Like all antibodies, and I demonstrated earlier, antibodies have a life cycle. ERG is probably mid-life or early older age. And although very useful for vascular tumors and things like carcinoma of the prostate and so on, it does come up in other tumor types, some Ewing variants, sick duct fusions. Ken will talk about those later. The acrofibroblastic tumor I'm going to mention later, and in some other tumor types as well. And I'm seeing it now, for example, in cutaneous fibrocystic So again, it will find its place in a very specific niche, but be careful if it comes up in something that is not what it should be. Now, we've just heard an excellent presentation about NTRK rearranged tumors and their treatments, two excellent presentations as well on this topic. So I'll just go through this fairly quickly, but this is now an emerging concept of NTRK rearranged tumors. And the subtypes, again, depend on site and clinical behavior. So we have lipofibromatosis-like neural tumor, some adult fibrous and infantile fibrous sarcomas, some that are not classified as fibrous sarcomas but still infantile, some subtypes of IMT, and also a subset of uterine spindle cell sarcomas. As you know, these are variably CD34 and S100 positive, but lack out SOX10, which helps distinguish them from nerve tumors, and the Pantrac antibody we've heard about as well, and the pattern of staining may give you a clue as to the fusion gene. And of course, you've also heard already about the value of this and the need to assess these cases for potential for therapy. Just a little bit about a couple of these subtypes, lipofibromatosis-like neural tumor, described in younger adults in the lower extremity. Obviously younger because it looks like lipofibromatosis, which is a childhood tumor of extremities. Deep dermis and subcutis, and it infiltrates in this irregular pattern with cellular fibrous septa infiltrating the fat and forming a honeycomb. It has low mitotic activity. There can be focal nuclear atypia, which can mislead you. In a way, this is a mimic of malignancy, but it is not an aggressive neoplasm. And this has CD34, S100, and no SOX10. Always a good combination for this tumor type. No muscle markers, no ERG, and you'll see why that's important in a minute. Now, fibrous sarcomas, or frank spindle cell sarcomas with MTRAC3 fusions, have been described in soft tissue, and here they are. And this is good for fibrous sarcoma. I don't like to diagnose fibrous sarcoma until everything else is excluded. And even then, they've got to have a nice sweeping fascicular or herringbone pattern. I think this fits pretty well. You do also have often in MTRAC rearranged tumors thick collagen bundles or amianthoid fibers, not present in these pictures, but I just wanted to show you this fibrous sarcoma pattern. This can have variable mitoses and is CD34 positive and S100 negative. So this could give you quite a problem, fibrosarcomatous DFSP, for example. So you do need, when you get a tumor like this, to try and get molecular investigation further to characterize it. This is another very nice case kindly provided by Kin, in which the TPM3 NTRAC1 sarcoma, confirmed by NGS, the primary tumor was pleomorphic and had very little CD34 expression. However, this tumor metastasized, and the metastasis is bland, much more typical of an NTRAC rearranged sarcoma. You can see the thick collagen bundles here, and CD34 has reappeared. So this is counterintuitive in that the metastasis is better looking than the primary. So the behavior of these tumors spans a spectrum. It's not always predictable. This also had focal S100 protein. So actually, if you didn't know, and remember my urging you this morning always to check the history in previous tumors, if you didn't know, you'd call this MPNST because it's got focal S100 and some CD34, which you can get. Now, this spectrum has been expanded, and you've also heard a bit about this today, to other partner genes which have S100 and CD34 co-expression, RAF1, BRAF, and some NTRAC genes. A number of, so commonly in soft tissue work, 3 papers come out, well, 2 at once here, these 2 at once and then a third. But same thing is often described almost simultaneously from different centers. And they all give different names, which leads to a pitched battle later as who shall win. So just derived from those studies, I've just listed some of the translocations that can be found with RAF1, RET, and BRAF mutations and fusions in these genes. The histology varies, and many of them have the typical thick, irregular collagen bundles and perivascular hyalinization, and can be pleomorphic or very cellular. But some of them resemble infantile fibrosarcoma with this very typical pattern of infiltration of skeletal muscle and bland, short spindle cells. Notice also the hemangiopericytic pattern that is not uncommon in these translocation sarcomas. So that was fibroblastic tumors. I'm going to go on now to myofibroblastic tumors. So this is another field where there's been considerable development due to molecular investigation. This is necessary because these tumors all look a bit the same. They're all composed of the same cell type. And they all have the same immunohistochemistry with smooth muscle actin, calponin, sometimes focal desmin, and sometimes caldesmon. There's a variation with the caldesmon according to your antibody. They technically are negative in myofibroblastic tumors. We are finding positivity. So fasciitis, fibromatosis, a low-grade myofibroblastic sarcoma, inflammatory myofibroblastic tumor. Pleomorphic myofibrosarcoma is simply UPS, which has, as Kin showed nicely earlier, very nice plasma lemon SMA, so myofibroblastic differentiation. Here's the spectrum: nodular fasciitis we've seen, fibromatosis we've seen, low-grade myofibrosarcoma we've heard about, more cellular with atypia, and inflammatory myofibroblastic tumor with these fascicles of myofibroblast and an intense inflammatory infiltrate, in this case of plasma cells. And once again, each of these is genetically distinct. We've heard about the fasciitis fusions and fibromatosis and low-grade myofibrosarcoma, which has nothing specific. Incidentally, it has this 12q13 amplicon abnormalities, which is quite common in low-grade sarcomas. And IMT we'll talk about has lots of rearrangements. So let's go on to that now. And this was originally described in two papers. First as inflammatory fibrosarcoma, and then that was the era when it was fashionable to define tumors by the stroma. And then now called inflammatory myofibroblastic tumor. It was predominantly a childhood tumor with a mean age of 8. In viscera, lung, intra-abdominally, and then urinary tract distinct subset, and now in other sites as well. Often multinodular and infiltrative. This is infiltrating the pancreas in a retroperitoneal tumor. And systemic symptoms are sometimes found in the child, like fever, because of various kines being secreted, cytokines. It's essentially an intermediate tumor. I think that figure's lower now, but about a third recur, which is quite normal for intermediate type soft tissue tumors. And I think this is probably lower too, although some can undergo sarcomatous transformation. Histologically, this is supposed to have 3 patterns. That's to say, the fasciitis-like pattern, the smooth muscle tumor-like pattern, the sclerosing pattern, and also, in addition, scattered ganglion-like cells. And notice that all of these have an infiltrate of inflammatory cells, predominantly plasma cells, in this case, neutrophils as well, and some eosinophils. So there's a summary of those features, and it's worth bearing in mind that some of these have raised IgG4 plasma cell percentage with storiform fibrosis and obliterative phlebitis, in other words, the features of hyper IgG4 disease. There's some overlap. Immunohistochemistry, smooth muscle actin, and ALK. And ALK positivity is very useful for diagnosis. This is strong cytoplasmic in this case. Other markers, not so much. You can get muscle-specific actin, a bit of desmin, and some of them have cytokeratin, particularly in the abdomen, which can cause difficulty. But the morphology is fairly distinctive. However, ALK is only positive in about 2/3 of cases even today. Note how the percentage has gone up with increasing sensitivity of the immunohistochemistry and with increasing accuracy of diagnosis, I suspect. But also note that it depends which clone you use. ALK1 is not as sensitive as, say, D5F3. And the positivity is predominantly in childhood tumors in abdomen or lung, not so much in adults, so it can't be used so readily for diagnosis. And by the way, ALK also comes up in other tumor types, epithelioid, fibrocystic and geomatoid FH, I'll talk about later, and some other sarcomas. Genetically, IMT is having a field day. It's got so many fusions, it doesn't know where to start. Most of them are with ALK, but increasingly we have ROS1, and now we have some others, including, I mentioned, ETV-Zentrac3, contentious whether that's inflamed infantile fibrosarcoma, goes back to, do you call it by the morphology or by the genetics, and some others as well. The pattern of expression can give a clue to the genetics, mostly cytoplasmic. One particular, the RAMPP2 nuclear pore protein, has a very distinct round expression, and you'll see in a moment, a ring expression. And this is a variant called epithelial inflammatory myofibroblastic sarcoma. It was initially an intra-abdominal tumor and then appeared in the pleural cavity and lung, and it can be multifocal. It's a high-grade tumor with high recurrence and metastases. In addition to the usual appearance of IMT, it also has lots of ganglion-like cells. The ALK is very striking. It gives a ring pattern with the positivity on the nuclear membrane, and that's, if you see that, if you think to do an ALK and you see that, then you're almost home and dry for diagnosis, because there's a problem, which you will see. There's a summary of the features: vesicular nuclei, large nucleoli, and inflammatory cells. And the problem is, there's the ALK, the problem is these tumors are also desmin positive and CD34 positive. So if you think it's a rhabdo, you do a desmin and it will be. If you think it's an anaplastic large cell lymphoma, CD30 and ALK, there you go. So you need to be very careful. You need to take into account all the factors I mentioned in my first presentation this morning. Now, two tumors that have expanded the myofibroma myopericytoma category, SRF-RELA fusions, are a tumor, again, described fairly recently, 2017, and all these are coming out now because of the widespread use of NGS, and we're discovering new fusions all the time. You have to say, did we know these tumors before, and what were they? Well, these were a subset of myofibroma, and as you can see, this is a benign tumor, essentially. So in a sense, that there's no sort of major clinical implication, but the implications for diagnosis and genetic and interrelationships between tumor types are very interesting. So this occurs in deep soft tissue in several parts of the body, including the bowel. It can be circumscribed or infiltrated. And it comprises cellular fascicles of spindle or ovoid cells. And this will remind you immediately of the two patterns of infantile myofibroma, with the cellular hemangiopericitic center and the fascicles of myofibroblasts or myopericytes peripherally. This has low mitotic index, no necrosis, can have focal calcification, and has SRF-RELA, but also some other partner genes from time to time. This is interesting because the immunohistochemistry, unlike the usual myofibroma, myopericytoma, it has three muscle markers, smooth muscle markers, SMA, desmin, CALDESMA. So you could think this is a smooth muscle tumor. If you get a tumor looking like this with three muscle markers, think it might be SRF-RELA. And of course, check the myogenin just in case it's some sort of rhabdo. Subsequently, a related or similar tumor was described under a slightly different name of cellular myeloid neoplasms with SRF-ICA1L fusions. And this is important to distinguish because it's malignant, or can be. Again, a deep soft tissue tumor, one case with lung metastasis. And this is a little bit similar, but more of a cellular spindle cell tumor with lots of mitoses. You can actually see them on this magnification. Hyalinized stroma, focal necrosis. This has SMA and calponin and maybe smooth muscle myosin, but no desmin or CALDESMA. So actually, we've got two different patterns of immunophenotype here, and the other markers negative, very occasional cytokeratin. So if you get a myopericytic or a myeloid tumor or a myofibroblastic looking tumor with these patterns, then just keep these tumors in mind, because you need to distinguish potentially malignant tumors from that. And in this particular situation, you will have some malignant features with a high mitotic index and necrosis, but you might not, because it's focal and it's not in every case. So pay attention to the detailed immuno and keep this in mind. So let's move on now to MPNST, which you've heard a little bit about, and I just want to talk about a couple of aspects of this. This is most common in patients with neurofibromatosis type 1, in which situation they do worse. They occur at a younger age group, they're more central and more aggressive. They can arise following therapeutic irradiation, but normally they arise from a nerve, nerve trunk or neurofibroma, very rare in schwannoma, we discussed that already, and present as a painful mass or with paresthesia. The histology typically cellular fascicles with intervening less fascicular zebra stripe, if you will. Neuroid whorls, very typical of MPNST, is this subintimal infiltrate of small blood vessels by tumor cells. And the nuclear morphology, as I mentioned earlier, with the buckled or lanceolate nuclei. Now, the problem with MPNST is there's no real specific reliable diagnostic marker. We've discussed already that S100 protein is positive in about half of the cases, and so is SOX10. If you use the two together, you might pick up a few more. But all the other markers shown here can be expressed focally, and the whole pattern is not particularly specific. Note you can also get TLE1, which is not specific for synovial sarcoma. There is the S100 protein, as somebody asked about that this morning. You can see it's focal, as is the SOX10 in MPNST, and H3K27ME3 is positive, but can be lost in some nerve sheath tumors, and we'll talk about that in a moment. Just a word about SOX10. This is a very useful marker. It stains, or rather it's picked up in neural crest-derived cells, melanocyte-1 cells, myopithelial cells. So benign nerve sheath tumors are strongly positive. It's a nuclear stain. MPNST about half, synovial sarcoma a few, and also useful for clear cell sarcoma, soft tissue, myoepithelial tumors, and salivary gland tumors. This is even worse because there are no specific diagnostic genetics for MPNST. So what do we have? We have various abnormalities in NF1. We have loss of P16 maybe. EGFR overexpression is not diagnostically useful. Loss of H3K27 trimethylated can be useful because in a suspected MPNST, the loss will help to support the diagnosis. About half of the tumors, particularly the higher grade ones, are negative, particularly also in post-radiation MPNST, most of them or all of them, but also other tumors can lose it, including some melanomas, often with a mosaic pattern, which is a bit annoying when you're trying to diagnose desmoplastic melanoma versus MPNST. But it has its place like all others, but it should be kept firmly in its place. Now, a relatively new concept is the concept of atypical neurofibromatous neoplasm of uncertain biologic potential, or ANUB. The problem here is that particularly neurofibromas undergo a series of changes through hypercellular to atypia to frank malignant change. And we have to try and guess malignant potential. So there has been identified a subset of tumors of uncertain malignant potential that don't quite amount to malignancy. And the criteria for this are not nuclear atypia alone, but two of atypia, loss of neurofibroma architecture, high cellularity, and mitoses, very specifically defined as more than 1 in 50, but fewer than 3 per 10 high power fields. This is what it might look like with increased cellularity, focal atypia, and no mitoses, because 1 for 50 is quite hard to find very many. The immunohistochemistry, unlike MPNST, the widespread staining is retained of S100 protein SOX10, as is the H3K27 and the CD34 positive fibroblasts that are a part of the pattern of neurofibroma. But the Ki67 is increased, which might be a clue to use to look for more mitoses. Now, almost finally, I just want to mention glia-range tumors. Now, this is not a spindle cell tumor, but it's an S100 protein positive tumor, so it can be confused with nerve sheaths, although it's SOX10 negative. And this is a molecularly defined, again, tumor, which has a very characteristic appearance, which, however, looks like several other tumors, including carcinoid, clear cell sarcoma, and so on, found in various locations. I've seen, I think, 2 in the abdomen, nests and cords of epithelioid cells with a pericytomatous pattern, high mitotic index and necrosis. It's a malignant neoplasm. Some of them have Gli amplification, not rearrangement. And I think, yeah. And this is a case again from Dr. Sway, who sees incredible amount of great material. And this is an example that she had, which she kindly passed on. And these first three show a very similar pattern of these chords, almost carcinoid-like or medullary carcinoma, thyroid-like chords. And this is a Gli amplified tumor. Oops, so sorry. Let me just apologize for that. This is a Gli amplified tumor showing you what could be anything in sclerosed fibrostroma. The clue then is S100 positivity with nothing else. And there it is with SOX10 and the other markers negative. The partner genes are variable, ACTB, PTCH1, MALAT1. And in the amplified group, the immunohistochemistry is slightly different, with S100 protein and sometimes a bit of keratin, but again, no S100. Interestingly, the Gli gene, as you will see, is on the 12q13. So when the Gli is amplified, so is the MDM2 and the CDK4 and the STAT6. So this may be STAT6 positive. And you may also, if you think it's a DDL, you'll find MDM2 and you will call it dedifferentiated liposarcoma incorrectly. Finally, synovial sarcoma, just a few words. Of course, we're familiar with this as a biphasic tumor. And there is the typical biphasic pattern with epithelial glandular formation, sometimes rarely keratinization in the epithelial inverted commas element. And here's the monophasic synovial with the uniform fascicles of spindle cells with the now familiar to you overlapping nuclei. And there is a high-grade, poorly differentiated variant, which is a small round cell tumor. I'm sure Kim will mention this later. Immunohistochemistry, focal positivity epithelial markers, not in every case, and then other markers as well in varying degree. And note the use of TLE1, which is very useful in the sense it's positive in pretty much all synovials of all types. But it is positive in other tumors. There's MPNST with TLE1. And it's most useful when negative, as with some other tumor antibodies that we already discussed. Now, what's new is the genetics, because this tumor is SS18SX. Sorry, the molecular pathology of sarcoma is no place for slight dyslexia. SS18SSX fusion genes. And the SSX, of course, is of 5 types, of which only 3 take part in the fusion, mostly SSX1, the rest mostly SSX2, and a very few with SSX4. But now, and this has been an extremely faithful partnership, but now we're getting some new things. There's SS18L1, SS18NEDD4, EWSR1SSX, which I'll talk about, and MIN1 actually, SSX1. So where FISH has been incredibly useful for SS18, SSX, and we use the FISH is the probe to SS18, which was called SYT, but only for those where that is in the translocation. So some of these will not be picked up. So if you have a barn door or a very clear-cut synovial sarcoma with negative FISH, do the PCR or do the NGS just to confirm or support your diagnosis. Should these be called synovial, we can discuss a little later. And just, this is the last slide, I just wanted to show you what's coming along the tracks. And now there's an antibody to the SS18 SSX fusion. And this is 100% specific and 95% sensitive so far. And by the way, I just want to bring this to your attention, that this Hugo Gene Nomenclature Committee recommendation came out actually about a week ago, or this week, in print, but online in October the 6th, I think. And unless you regularly read leukemia, you would have missed it. But it has been decided that the usual convention of fusions, like SS18-SSX, shall be replaced with 2 colons. Just so you know. Thank you very much. That concludes that presentation.